current performance measures actually do a good job of assessing whether patients are prescribed certain medications or not, but not the potency of the treatment. So in a paper in JACC, the authors wonder whether it's time to go beyond medication prescription as a performance measure. This is from the November 5th issue of JACC, and I am with Suzanne Arnold, MD of St. Luke's Mid-America Heart Institute at the University of Missouri, Kansas City. What a problem you found in this study. Can you first give me an idea of why you did this study?
Well, I think this comes from clinical practice. We see in cardiology all the time people being discharged after an MI on, very low doses of beta blockers or ACE inhibitors, and people thinking, oh, yep, got the job done. And we really wanted to quantify how many people were actually being discharged on these very low doses of medications that we know by the clinical trials need to be at higher doses to really be effective.
Now, there are clinical indications where it's understandable why they might be discharged, correct, on a low dose of a secondary prevention med.
Absolutely. If people have borderline blood pressures, they're going to need to be up titrated very slowly, or if they have LV dysfunction, we know with beta blockers, we want a slower titration, and slower titration is okay as long as titration actually happens.
Yes,
and so that's what we wanted to do, is both look at discharge meds, but also what happened over the next 6 to 12 months during follow-up. And, if they weren't at goal doses at discharge, were they at follow-up?
Now, this was a fairly large group of people you were looking at, more than 6,000 if I remember right.
More than 6,000 people, 31 hospitals in the U.S. Over a span of about 5 to 10 years.
And what did you find?
We found, not surprisingly, about 87-90% of patients were discharged that were eligible were discharged on some dose of these 3 medication classes, which we quantified with beta blockers, ACE inhibitors, and ARBs for LV dysfunction, and statins.
Now, that's excellent.
Very good, very good. And so we're achieving our performance measures by
right.
kind of how we're measuring it.
However,
Only about 1 in 4 to 1 in 3 patients that would have been eligible for being on higher doses were actually discharged on goal doses of medications. And beyond that, only a quarter of patients were up titrated over 6 to 12 months of follow-up. So basically, whatever they were discharged on was what they were on at follow-up.
So I don't think we can assume that all of these patients were hemodynamically compromised at exit, correct?
Right. We explicitly excluded people that had systolic blood pressures less than 100. We also looked at patients that had to have blood pressures over 110 to say they were able to be titrated. And even those, it was only 20-25% that were discharged on goal doses. Mean blood pressure was over 120 in these patients that were discharged on low or moderate doses of beta blockers and ACE inhibitors and ARBs.
Okay, so what do we do about it?
That's a great question. I think that it's very complex because the way that we measure performance measures now is at the time of discharge. And I think that incorporating some sort of goal dosing, particularly with statins, where there's no real need to up-titrate these patients, that could certainly be helpful. So judging hospitals not only on a yes-no, but on are they at least trying to get people on good doses at discharge. But the better question is, what do we do at follow-up? And right now, there are no performance measures for outpatient follow-up. I think in some organizations where, say, like a Kaiser or something where you have continued care from discharge through follow-up, there's some ability to judge that. But I think it's going to be really challenging. I think that one of the first things is education. I think a lot of outpatient physicians don't have a sense of what these goal doses really are, and they look at patients and say, oh, they're on a beta blocker or they're on a statin, and they don't pay attention to up titration. Right, exactly. They don't even think of it being as a goal of treatment. I think that's one of the reasons why we saw patients with heart failure being more likely to be on goal doses. These would be the people you think would be hardest to up titrate, right. But they're the people we're paying most attention to, where they're trying to get them on higher doses, but we don't think about it in kind of the general AMI population.
I mean, there's a whole discharge management program at many facilities, so there really just needs to be some education that goes to the receiving doctor saying, remember to up-titrate?
Right. Yeah. I mean, I think that communication is a challenge whenever you're discharging a patient. You're getting that handoff of care. Transitions of care, I think, are huge areas of errors, not just for this particular area, but other areas as well. So some way to communicate between the discharging physicians and the outpatient physicians that are going to be taking care of the patients, that this needs to be a goal is important.
So a large majority of patients are not at goal when they leave the hospital, nor a year later.
Correct.
That is depressing. And all the details are in JACC. It's the November 5th issue of JACC, and it's Arnold et al., and we have more coming from the American Heart Association meeting, which is where we're taping this program for CardioSource World News. I'm Rick McGuire.